Hello and welcome to this very special webinar on the right heart disease for our exclusive guests. This is something that we try to do more frequently now. And with me, I have Martin Altersberger, who many of you already know. He's been in a lot of the lectures we've held so far, and he's part of our team. And obviously, you'll see much more content from him going forward. Hi, Martin.
Hi, Tommy. Thank you very much again. It's a pleasure for me being here. We will see a lot of new things on the right heart, a lot of diseases. There are so many questions coming in from you. And shall we start right away?
Yeah, I guess that's what we'll do. Yes, thanks a lot for the many questions we got. Basically, this is the way it works. You know, you get the invitation, you can send us questions, and of course you can also ask questions while you're here in this webinar. You can put them in this little chat box, we'll read them and then try to answer them spontaneously. And of course we prepared some cases and some slides just to kind of give you the answers to the questions you've asked so far. So I guess we'll start right away. And one of the questions we got from Jamal was, can you explain the atypical views of the right ventricle? Now, this is something we brought in the right heart course, and we emphasize that very strongly because we believe it's very important. Why, Martin?
So why is this important? The right heart, if you just see it from a four-chamber view, you just have, let's say, limited information about the right heart. So what are the atypical views to start with? Here you see a two-chamber view of the right heart. You see the right atrium and the right ventricle, and here a right ventricular inflow-outflow tract view. So how can you achieve those views? You start in a normal four-chamber view, and then, like with the left ventricle, you just turn the transducer. You turn counterclockwise, then you get to the right ventricular inflow-outflow tract view, and if you rotate a little bit more, you get to the right heart two-chamber view. But these are not the only atypical views, there are more, just that you have seen them. If you are in a parasternal long axis view and you tilt the transducer a little bit cranially, you see here a nice view of the pulmonic valve. And if you tilt it caudally, you see again the right atrium and the right ventricle, so the parasternal long axis of the right ventricle. This view, keep it in mind, this will be very, very important for another question. So why should you use those views? So if you have a normal healthy heart and you don't find anything special, should you perform these views as well? For reasons of practicing, I would say yes, but especially if you have maybe a dilated right atrium or some kind of pathology and you think there could be something wrong, also perform those atypical views. Especially here in this right ventricular long axis view, you have a really good view of the tricuspid valve. So the anterior and the posterior leaflet, you can distinguish them there. And in all views, take a look at the function of the right ventricle.
Yeah, I think this is very important. When you perform these views, remember, the right ventricle obviously is a three-dimensional structure, just as the left ventricle is. And why shouldn't we also look at all different segments of the right ventricle? Especially in the apical views, if you turn to the two or to the apical long axis view, you can even note that there is regional wall motion abnormalities. Sometimes, you might have regional infarcts, just as you have regional infarcts of the left ventricle. So this is something that you can utilize as well. And particularly when you look at this view here on the left, this is a view of the pulmonic artery, a view that we regularly don't do. It's one of these, I think, 3 or 4 views that you can achieve to image the pulmonic artery. And as Martin mentioned, all you need to do is you do a kind of a 4-chamber view, then you switch to the 5-chamber view, and then you tilt even more cranial or more ventral actually. So you achieve a view of the pulmonic artery such as this. Now you will not get this in every patient, but in some situations, you can even measure the pulmonary artery velocity, or you can look at a PR signal. So I guess it's very helpful.
And it's very useful, especially if you're in a short axis view and you cannot visualize the pulmonic valve. Then very often other views can help you to visualize the structures you have to find in an examination.
Right. So use these views. Of course, if you have 3D, you can also perform calculations of 3D volumes and ejection fraction. But if you want to look at the morphology, it's usually better to look at the 2D image. So this actually brings us to another question that we got, which kind of, I would say, connects to the question that we heard previously from Nevilla, and she wants to know, do you think the speckle tracking should be included in the guidelines as one of the techniques for the evaluation of the function of the right ventricle? So what is your take here?
Yeah, basically I love those kind of questions, and this is a question where the answer basically is easy. It is already mentioned in the guidelines of heart chambers and walls from 2015, but we have to be aware it is mentioned in the guidelines in a form that they state a normal function is below -20, so meaning -21, -22, that's normal. Mm-hmm. But I would say from my experience, and Tommy, I think you will agree, you need way more than -20 or -21 for the right ventricle to state that this is normal right ventricular function. So maybe -25, -28 in that range probably, even -30 probably.
You know, I've been talking to a lot of colleagues who are very, of course, knowledgeable about the strain of the right ventricle, and we all agree, I don't know where they got these normal values from. I have no idea, because if you perform a strain analysis in a normal patient, as Martin said, you'll get definitely over 25, sometimes over 30 or 35 even. And the reason is clear. The normal right ventricle has more longitudinal contraction than actually radial contraction. That's why the right ventricle has higher longitudinal strain. So this is very important to keep in mind. And as Martin mentioned, it's in the guidelines. Now, it's not said that it's a mandatory measurement you have to do, but it is listed as one of the alternatives you have to quantify right ventricle function. And my experience with this technology is it's a very, very important way of looking at the right ventricle. And I think it's also probably more sensitive and even specific to right ventricular dysfunction than, for example, TAPSE or TDI or the right ventricle area. Because what you have here is you have a parameter which is a more global parameter. Since you are looking at several segments, you're looking at the apical segment, the basal, and of course the mid segment. While with the TAPSE and the TDI, you're only looking at the basal segment. Of course, the volumetric measurements, they too reflect global function. So there you also have a component of radial function inside. And that's why you sometimes have a difference between the measurements or the quantification of right ventricular function if you look at the volumes versus if you're looking at the right ventricle. So I think it's an interesting topic, of course, and it's very difficult sometimes to understand why some of these parameters are better than other parameters. But I guess that's just the way it is.
And I think, just to add a little bit, because that's maybe the main teaching point, or a really good teaching point. If you have the TAPSE, you just look at the basal part, as you mentioned. And sometimes if you're in a hurry or whatever, you don't look at the right ventricle thoroughly, then you can oversee that not all the segments contract properly. So there the strain definitely helps. And also the TDI, it's basically the same like the TAPSE. You only look at one segment, and there you can oversee a lot of pathologies.
Mm-hmm. Right. Maybe we can go back to this about chronic thromboembolic pulmonary hypertension and display some of the typical features you see here.
Yeah, what can we see here? We just have to repeat the loops a little bit. What you see nicely here is this D-shaped left ventricle. Always take a look at this finding already in a peristernal short axis view. And if you are in a 4-chamber view, just look at the right heart. And here, this is a nice example where you see that basically the TDI might not be that bad, especially when you just take a closer look. But overall, what would you say, Tommy, to global right ventricular function?
Well, it's definitely reduced. Yeah. You can tell that the area is not really decreasing. You see that there's not much longitudinal function. So even by eyeballing, which I believe is a very important primary parameter to look at right ventricular function, you will, I guess, agree that right ventricular function is not normal here. Now, from my experience, most patients, I would say almost every patient with significant pulmonary hypertension has some degree of right ventricular dysfunction. This is clear if you understand the evolution of the heart. Now, the heart obviously is not adapted to cope with high pressures. So it fails quite quickly if pressure rises. The only exception is if you have a patient who has pulmonary pressure in the early phases of his life. In other words, at a time when the right ventricle is still taking the main load and the right ventricle is still adapted to high pressures shortly after birth, then these patients sometimes have almost completely normal right ventricular function in the setting of very severe pulmonary hypertension. So it's important to understand that there's a little bit of a difference between patients who have born pulmonary hypertension versus those who acquire pulmonary hypertension. And that's why, honestly speaking, if you see a patient with pulmonary hypertension, which is significant, you can kind of assume that right ventricular function cannot be normal.
And just coming back to strain, you see here a strain analysis of the free right ventricular wall. And what you see are the values -10, -9, -10. So here again, you see that also with eyeballing, we thought right ventricular function is deteriorated, and here we see it in strain as well. So not good right ventricular function.
Yes, and there's been some thoughts about, is this sufficient? Now again, we're only looking at a part of the right ventricle. Martin initially showed you that we can look at the right ventricle also in other views. You can look at it with a two-chamber view and an apical long axis view, or actually an inflow-outflow view. So in essence, you would probably be more exact if you did analysis of strain in all three apical views. Now, we don't do this regular, and there's not much data out there to show you what the normal values are, but I believe that this will eventually be a technology or an approach that we'll be using in the future.
Yeah. And then again, eyeballing also helps in the other views as well.
Yeah, so there was one question from Neville, I believe, and she wanted to know, this is it. Do you think the best way to evaluate the function of the right ventricle, we should use speckle tracking in two projections, the four-chamber view and the peristernal long axis view of the right ventricle? Well, as I just previously mentioned, yes, you should use several views, but I don't think that the peristernal long axis view is actually the view that you should use. Why not, Martin?
Here you see in those two loops, it is displayed really nicely, the four-chamber view and the right ventricular peristernal long axis view. So what can you see here? We are here in an apical view, and here you can see the free lateral wall. Here in the long axis view, we are just not in the right, in the right projection of the right ventricle. So again, as Tommy mentioned, you have to look at the function. By eyeballing, you see it's normal. It's doing really fine, actually. Also in the four-chamber view, you can see here the free lateral wall. But for speckle tracking, we are also just lacking data here. So you can do it, basically. You can try. You will get measurements, but we don't have normal values.
Yeah. And I think the main point is that when we're looking at longitudinal function, it's best to use the apical views, because there you can see the decrease and increase of the myocardial length. But if you use a peristernal view, you're perpendicular or slanted, as in this peristernal long axis view, so it's not ideal. Now, even though speckle tracking is, you can say, angle independent, you should get some values here, but I would be very, very cautious in using a parameter that you obtain in such a view. And I guess the software has not been validated, but as always, I always recommend that you play around with these things and you try and get your own experience out of this. I think that's a very important part of becoming a master in echocardiography, that you also have your own experience and don't only rely on the literature.
May I ask, did you try that once?
Now, to be honest, I've never tried. I've never tried it in this view. But after this question, I guess I will. I'll go to the laboratory, and when the next patient is, I'm just going to see if it works. Yeah.
And play around.
Yeah.
I'm also curious about the values you can get here, because I also never had the idea of trying this. But yeah, curious.
Yeah. So the bottom line is, yes, you can try to use several views for the strain of the right ventricle. Maybe even this view, but the validated measurements are only for the apical four-chamber view or the slanted four-chamber view, where you look at the longitudinal function of the free lateral wall. Let me go back again to a part that is actually in the right heart course, and again show you how such a strain measurement is actually performed. So this is something that is in the course, and we'll just let you take a look at this. It's I guess only 2 or 3 minutes long. parameter I want to show you is my favorite parameter, is right ventricular strain. What is it? Well, basically, we're using a technology which is called speckle tracking. Here we are tracking the motion of these bright little echoes that you see throughout the entire myocardium here. And with this, you're able to actually look at the percentage shortening of the myocardium. Especially important is the motion of the longitudinal function, which can be assessed both for the left and for the right ventricle. Now, the left ventricle, of course, was the first ventricle that we used speckle tracking on, and there's just so much data that shows it's an early marker of left ventricular function, and there's just so much data on this already. But there's also an increasing amount of data on the right ventricle showing that it works quite nicely. We're, of course, defining first of all which parts of the right ventricle should be tracked. In this case, we're only tracking here the lateral wall. And then we perform the analysis, and the system basically gives us a percentage value of contraction, in this case of the lateral wall. And this is a methodology which allows you to do a lot of calculations. Not only can we look at the entire myocardium, but also look at the individual segments, the base, the mid, and the apex. We have different ways of displaying these curves and the data. But the bottom line is that we now know that there is a value that is somewhere in the range of minus 27, 28, which is normal. Now, this is a value which is higher than the global longitudinal strain that you will use for the left ventricle, simply because longitudinal contraction. And there's been some discussions in the literature with different papers showing different cutoff values. Here we had some papers where the values were probably too low, but speckle tracking is now included in the guidelines as a methodology that you can use to assess right ventricle function. Yeah, so this is part of the right heart course, and we expand on the topic of strain analysis of the right ventricle also in our speckle tracking course, where we show you much more of how it is performed, how the values look in different clinical scenarios, and basically what the value of a right ventricle strain actually is. So I guess these courses are a little bit complementary when it comes to looking at the strain and the strain function.
I'm just seeing there are two questions coming into live questions. The first question is, now you show the strain of the right ventricle, why don't you include the septum? So, Tommy, why don't you include the septum?
Well, it's a good question. This discussion is not fully over yet, because there are people who actually do use the septum. The septum, in reality, contributes both to the left and to the right ventricle, probably much more to the left than to the right ventricle. So some authors and some people actually say that you should include it. I personally think that it is better to not include it, because what if you have a left heart pathology? Then this kind of comes into play with the right ventricle function, and you're not looking at isolated dysfunction of the right ventricle. So basically, we focus only on the free lateral wall of the right ventricle, and my thought would be that this is also how it will go in the future. There's more and more vendors are now devising software which allows you to specifically look at the right ventricle, because so far what we've been using is we've been using the same software as we use for the left ventricle, only that we contour the right ventricle. Now we're gaining more and more experience there, which will be very helpful, because when you look at these algorithms, it's not just tracking of the myocardium, but it's also using machine learning algorithms. So the software starts to realize what the shape of the right ventricle is, and it gets information about how segments actually contract normally. And this is also integrated into analysis. And if you devise specific programs for the right ventricle, I believe that the sensitivity and the quality of these parameters will get even more. And I believe, I haven't seen the latest software here from all vendors, but they will mainly focus on the free wall, or they will have alternative measurements that allow you to also include the septum.
Mm-hmm. Thank you very much. There's another question from Sun Nong. May I start a little bit?
Please, go ahead.
So first, what you have to differentiate is an acute and a chronic state. So if you have an acute state compared to a chronic state, let's think about first high pressures. What do high pressures do? The ventricle has to use more of his strength to really pump against this high pressure. So what will it do? It will become hypertrophic. So where do you look at hypertrophy? Subcostal view, and then you can see it. In volume overload, the right ventricle has to use the power against a lot of volume, but it will dilate. So reduction in right ventricular function and dilatation of the right ventricle. In an acute state, you cannot see actually if it's pressure or volume overload because you don't have a thicker right ventricular myocardium.
Yeah, that's a very, very important part. So looking at the thickness of the myocardium can already help to tell you if it's pressure or volume overload. As Martin mentioned, you only have to be aware that in acute pressure overload, you might not see hypertrophy yet because it does take some time. And there's another thing that you should consider is that the dilatation of the right ventricle. Basically, you will see it both in pressure and volume overload because, as mentioned, most patients who have acute or chronic pressure overload are not adapted to this, so the compensatory reaction is always a dilatation. So the dilatation will be the same with the exception, again, of those patients who have congenital pulmonary high pressures or high afterload or pulmonic stenosis, because they will have often very small concentric ventricles with high hypertrophy there. And then there's one other thing that you can look at, and that is the position of the septum. Now, in both situations, volume and pressure overload, you will have a D-shaped kind of a shape of the left ventricle. The only difference is that if you have pressure overload, you will have it in systole more prominent, while if you have volume overload, you will have it more in diastole. I think this is the bottom line. Some patient, but if you have these additional findings of TR and pulmonary pressures, then you can make it. And don't forget, frequently you have both. You have pressure and volume overload. So you have a combination of this. Good. Let's move on. What useful ultrasound science to help realize more certainly that the right heart assist device is more critically needed than left heart assist device in the setting of acute cardiogenic shock. And there was a second question dealing with the LVAD, and what I'll try to do is I'll pack these two questions kind of together. And the question was, in a case of an acute cardiogenic shock situation, does an enlarged right heart on echo and small left heart chamber always mean that mostly right heart is failing? Then let me show you a case. Now, it's a case of a 25-year-old Lithuanian who had a ski vacation in Austria. As you know, Austria is kind of famous for the skiing resorts. And as a matter of fact, I just came back from a ski resort. And we have a lot of tourists coming from all over the world. And he was from Lithuania. And he went skiing and, he noticed progressive dyspnea. And eventually he was in shock. And these were the findings on admission. He had a lactate, which was elevated. His NT-proBNP was 21,000. Massive pulmonic congestion, he had pleural effusion, shock liver, renal failure. So this guy was in a very, very poor state. And you can see his chest x-ray, huge heart, and pulmonic congestion. Now, I'm not the big believer in chest x-rays, but what you can see here is that the heart is large. So it doesn't really look like an acute condition that the patient has. So it looks probably more like a chronic, much more information. And here failure probably based on a chronic condition. The heart probably had a problem before, and now, with altitude and with other factors that might be involved, he just had this state of decompensation, and you see a very large left ventricle. But Martin, how would you describe now, let's say, the right ventricle here?
Yeah, here you see the right ventricle in a slanted view. And what you can see, the basal parts are still contracting, I would say, a little bit. So if you just place a TDI here, or a TAPSE, you would have maybe a deterioration in right ventricular function, but it would look overall better than if you would place it here, or just also look at the strain here. You see the mid segments, also the apical parts, they are basically not moving at all. So really poor left ventricular and really poor right ventricular function.
Yeah, I think it's just a beautiful example, right? I mean, you can see that this is the reason why the parameters sometimes don't fit together. TAPSE seems to be okay, but look at these mid and distal areas here, they're just very poor. Now let's move on. So the patient was successfully stabilized. He got catecholamines, and we performed a pleural tap, and everything was on a clinical grounds at least partially stabilized. But the question is this patient really stable? And here is a short axis view that looks at his heart. And what you can see here is you see this hypertrabeculations. I would be wondering if this maybe is not some form of non-compaction maybe. Very poor left ventricle function. His heart rate is high, so he's kind of really on the edge there. And then the next morning, boom, we're back to where we were. Clinical deterioration, lactate was rising again, he had respiratory insufficiency, anuria, progressive shock liver, and right and left ventricle function was deteriorating. Now, in this situation, I think what is always very important is to also look at findings such as pleural effusions and ascites, because they usually denote right heart failure. So if you have that, it's in my view always a very poor prognostic sign. Once you have this clinical scenario of pulmonary of pleural effusions, it's usually a bad clinical sign. And now in this situation, I guess it's quite clear. Here we have a patient where we have both left and right ventricle dysfunction. So the patient definitely needed an LVAD and an RVAD. There's beautiful overview articles which demonstrate what the criteria are of implanting an LVAD and what you have to be aware of. What we do not like to have in an LVAD is a very small LV size. The reason for this is that if you put a cannula into the left ventricle and the ventricle is small, it will suck on the myocardium, especially the septum, and the cannula can get occluded. So large left ventricles are better than small left ventricles. And of course, you would not want to have a thrombus in the left ventricle, because then you would have a complication, maybe the cannula can get obstructed or whatever. There might be an option where you actually even remove the thrombus and then place the cannula. We've had patients where we did this as well, but this gets into situations where it's more and more complicated. Apical aneurysms are not ideal because you're going through the apex with a cannula, which means that in essence, you're going through a scar or through an aneurysm, and you don't want to have ventricle septal defects, because again, you'll be sucking blood out of the left ventricle and also out of the right ventricle through the left ventricle cannula. So this is not very good to have as well. And for the right ventricle, what we're looking for is we're looking for a dilated right ventricle with poor right ventricle function. Those are the things that, let's put it this way, only an LVAD is not an option if you have poor right ventricle function. And this is what we have in this case. That's why we need a right ventricle LVAD as well. What else should you be looking for? A thrombus in the left atrial appendage, and an ASD or a PFO are also not good, because they also create shunts and cause hemodynamic deterioration if they're too large. Now, one big topic is aortic regurgitation. Here's an example of a patient who received an LVAD. You see that the aortic valve is not moving. That's normal, because now you're sucking blood out of the left ventricle, so there's no blood going through the aortic valve. It's being bypassed. The left ventricle is actually being bypassed. Now, in such a situation, if the aortic valve is incompetent, in other words, if you have aortic regurgitation, you'll be sucking blood out of the aorta as well. So AR is not a good thing to have in the setting of an LVAD. This is what we had in this specific patient here. And then there's other abnormalities you have to be looking at. For example, prosthetic valves are not good, and you should not have significant mitral regurgitation, no stenosis. TR should not be more than moderate or maybe mild, or you should not have more than mild tricuspid stenosis, and pulmonary stenosis is also not a good thing to have. And here is just a list of other things that you'd be aware of, which I do not want to go into in detail. But let's come back to this patient. And now you see, after implantation of the RVAD and LVAD, here's what actually happened. Now all of a sudden you have very good, flow across the LVAD with 4.4 liters and 2.1 across the RVAD. So the part of the right ventricle is still functioning well. You see that the aortic valve is not opening. Here's the cannula. You see that the blood is being kind of sucked out of the left ventricle. Now in this situation, you will be looking at certain things. For example, is there a connection or kind of a suction on the septum? You'll be looking at residual function, because your hope would be that the left ventricle recovers and then you can take out the LVAD again. And here you see from the LVAD just some contrast from an infusion in the pulmonary artery. This is just an image showing that we have cannulas in the right and the left. So coming back to the case, yes, everything was over. We thought catecholamines are reduced, improvement of renal function, and these LVADs can really help the function of the body if you have low cardiac output. And then we looked at, of course, the function of the LVAD. In this case, we had no opening of the aortic valve. Here we see again the cannula very nicely. Function is still poor, but the patient is stabilizing. We'd probably give him some time to see if we can recover. But then ultimately the question will be, does the patient need heart transplantation? You have two options. You have the option of taking out the LVAD again. Then you have what you can call kind of just a bridging, taking out the LVAD. Or you can ultimately bring the patient to transplantation, and you'll bridge him to transplantation. And this is the decision you must make, and that's why we perform echoes regularly, looking at how left ventricle function improves. This is the LVAD assessment. Here you have a different patient showing aortic regurgitation again. This is just a beautiful image showing you with the insertion of the cannula. You can look at all sorts of things here. In this patient we had a thrombus. Let me go back to this here on the right hand side. You see there's actually a thrombus in the aortic valve. This is one of the complications you can have with LVADs. Now you don't have any flow across the aortic valve, which means that there can be thrombi that form in the region of the aortic valve, and they can really be a problem because they can cause aortic regurgitation, as in this patient, and they can of course embolize. This is not the patient that I showed you. Just a 3D reconstruction showing the entry of the cannula into the aorta. Just nice images that you can produce. But coming back to our patient, they thought everything was over, but then again the patient developed tachycardia and he had a drop in flow in the LVAD and the RVAD, and all of a sudden we performed an echo, and this was the echo we got. Now this is a dramatic finding. If you take a look at this here, this is obviously some mass here. This is a long axis view of the right ventricle. Look at the tricuspid valve here. Is it closing? Not really, right?
No, not at all.
Not at all. So there's this huge mass here, and the question we had was this actually a thrombus or was this hematoma? The question was it inside or outside the heart? Well, it turned out it was a hematoma. So it was pressing from the outside. This is actually the contour of the right atrium. It was pressing on the heart, causing tamponade. Complication of surgery, there was just a leak somewhere from the cannula or some other bleeding into the pericardial sac, and those are pretty dramatic echo images. You can imagine how the patient was actually doing. Catastrophe echo is almost no left ventricle volume here.
It looks absolutely catastrophic.
Yeah.
Impressive images.
Yeah, that's what we thought too, but we were standing there deciding, well, what is it, inside or outside? But we were able to make the diagnosis, and ultimately we brought him to surgery. The hematomas were removed and he recovered, but then we had another problem. This time we had a thrombus on the cannula of the right heart. You see, this is the right atrium with the cannula, and this is the thrombus right here. So luckily the patient's right heart function recovered, so we were able to take this out and solve this problem, and actually the patient got better after this. His right ventricle function is still not normal, but he kind of recovered, and at the end he was stable, and he was dismissed home even without the LVAD eventually, and now we're assessing the patient for transplantation. But the conclusion is, it's not easy to sometimes answer the question, what are you supposed to do? Right or left ventricle LVAD assist device or not, but I guess all the parameters we showed you where you assess right ventricle function should come into play, and of course also clinical findings. So yeah, that's I guess the
very great patient to just illustrate how many things you have to think about if you ask such a complicated question. So it's not about just placing an RVAD, but also RVAD and LVAD. Yeah. Great images.
Yes. Another question we got is, how useful is the echo estimation of pulmonary capillary wedge pressure and pulmonary resistance? As an anesthesiologist, this is your question.
Yeah, so in right heart disease, so in echo you have certain formulas, the Nagier formula, for example, you could use to try to get an estimation of pulmonary capillary wedge pressure. I have also to admit, I never do it because I think it's just not accurate. For the right heart, you need the right heart catheter. What would you say, Tommy?
I just completely agreed. Yeah. There's, of course, with echocardiography, we also have the hope that we can, substitute invasive procedures, and we've managed with aortic stenosis. We never do, cath to look at the aortic stenosis, but it's clearly stated in the guidelines that right heart catheter is needed, first of all, to establish the diagnosis of pulmonary hypertension. Whether or not the patient has pre or post-capillary pulmonary hypertension. In pre-capillary pulmonary hypertension, you would have a high pulmonary vascular resistance, and also to determine the magnitude of the increase in pulmonary vascular resistance, because this actually dictates the treatment of the patient. You might play around with it and use the formulas that we have, but nobody I know would rely on these measurements to really make a definite decision whether or not you should go towards solving the left heart problem, or whether or not the patient needs some treatment of primary pulmonary hypertension or whatever. Just a slide to explain what pulmonary vascular resistance is. Now, in essence, what pulmonary vascular resistance is, it's the resistance of the pulmonary vascular bed to flow. In other words, how easily can the blood flow from the right ventricle through the pulmonary vascular circulation? If you have some form of microvascular obstruction or some form of problem in the microvascular bed, then this resistance will be high. And this means the problem is in the vascular bed. If you have, for example, a patient who has a normal pulmonary vascular resistance, but pulmonary hypertension, then the elevation of pressure is due to a problem of the left heart. So the left heart fails, pressures in the left atrium increase, and therefore the pressure translates through the pulmonary vascular circulation, but in reality, the pressure in the pulmonary circulation is not as high. Let's put it this way: the vessels are not constricted in the pulmonary vascular circulation. Be aware, though, that there could be a combination. You can have a post with a precapillary component. So these mixed pulmonary capillary pressures are important. And if you look at the formula of how it is calculated, you will see that basically we look at the mean pulmonary artery pressure and subtract it by the wedge pressure. Now, this is the pressure in the left atrium, basically. Correlates basically with the filling pressures of the left ventricle. In other words, it's the difference between pressures between the right and the left divided by the flow that goes through, the cardiac output, and then you use this factor of 80, then you get the pulmonary vascular resistance in DIN, and you can also use, of course, the Wood times 80, then you would get, which the Wood is the normal pressure times 80 would be the DIN. So this is the way you would look at it, and here you have the classic measurements. Between 20 and 130 would be normal. Between 0.25 and 1.6 would also be normal for the Wood resistance. So this is the principle of pulmonary vascular resistance, and in essence, there's it's very important because pulmonary vascular resistance is one of the best ways that you can assess the prognosis of patients with pulmonary hypertension. And as I mentioned, it's also important to decide which therapy you can use. For example, if you have a patient who has dilated cardiomyopathy and he has a very high pulmonary vascular resistance, this means he probably has an additional problem, and heart transplantation alone will not be the best option. So he's not a candidate for heart transplantation anymore. And the same actually holds true for patients with endarterectomy or even patients with congenital heart disease. If you have a patient with a ventricular septal defect and he has a high pulmonary vascular resistance, this means he already has fixed pulmonary hypertension, and therefore he would not be a candidate. So this is an important parameter. Be aware, though, that pulmonary vascular resistance can change, and it can also change with therapy. We know that, for example, if we do some provocative maneuver, for example, if the patient is on the catheter and we give him NO and we see that there's a drop in the pulmonary vascular resistance, we have hope that he is a so-called responder. In other words, that he would respond to therapy. And those are the patients where we initiate, pharmaceutical treatments. So a very important way of going about. I'll just skip this because this is just, I think, much too complex. And as I mentioned, it would just confuse you. If you're really interested in this, there's a lot of literature that you can look at where you get all the information of how you can get it. And I put this guy at the end of the presentation because after I presented it, I had the impression that all the people in the auditorium were looking like this. Kind of frustrated, and what am I going to do with this? So, I don't want to bore you with this because, waste of time. Yeah, go on a skiing holiday or do something else. I don't think it's useful.
But I think it's a quite important message because the right ventricle is rather complex. It was ignored for a very, very long time, and we have a lot of new techniques which can help. For example, the strain. That's a really good thing to do, but there are also things which might be too complicated for echo, or just we have no approach yet. For example, calculating the pulmonary capillary wedge pressure, which is just not accurate enough. Yeah. So I think that summarizes it really nicely, and also the explanations. It's like sitting there like this, being a little bit confused about all these measurements and findings.
Okay. So we got a question from Sabine, and Sabine wants to know, how important is right ventricular dysfunction in non-cardiovascular surgery and anesthesia? Martin, why do we look at right ventricular function, and why is it important?
So let me give you this approach. First of all, as you mentioned, what I think is very, very important is if you have poor right ventricular function, you could have, for example, pre-refusion. That would make breathing for the patient rather difficult. So right ventricular function, pre-refusion is very, very important. Especially, so another way to explain this, very, very often we have no echo before an operation. I personally think it's horrible. I want an echo for each and every patient should have an echo. Each and every patient should have an echo at all, so not even patients who have a surgery afterwards. So it's very, very important to know what you can face in an operation. So no matter if it's poor left ventricular function or right ventricular function, and especially with a worse right ventricle, you have to be very, very careful with volume. So it's very, very easy to create the status of a volume overload, and you don't want that. You can get into trouble so easily, and there an echo really can help you. Sometimes I did it during an operation, just a TTE, to see during an operation how the left ventricle and the right ventricle is doing to guide volume therapy. So this you have to know before an operation. And then again, with that deteriorated right ventricular function, you also have to see, is there ascites, is there pre-refusion present?
I mean, right ventricular function is definitely one of the factors that goes into the risk scores for operation, Euro scores or whatever score you want to use. And as Martin said, it's a good reason. And sometimes, we're just not aware that the right ventricle is poor, and the volume is a very crucial thing in these situations. And it's, I'm very difficult to steer the volume because on the one side they are intolerant to volume, on the other side they need a little bit of volume because if cardiac output drops, this is the only thing you can do. So it's this balance that kind of makes it very difficult. And of course, if you have poor right ventricular function, there might also be some underlying problem which you don't want to have during surgery, such as maybe you had a pulmonary embolism or something like that. So I'm not a general anesthesiologist, so I don't have so much experience with patients who are operated with poor right ventricular function in other settings, but I can tell you poor right ventricular function is one of the most threatened conditions you can have during cardiovascular surgery. And what often happens is that you see a further deterioration of right ventricular function after surgery, especially if you have a patient who has tricuspid regurgitation. But even in patients who have no tricuspid regurgitation. And what sometimes also happens is that when you close the sternum, right ventricle function deteriorates even further. So frequently when we see poor right ventricle function, we leave the sternum open even after surgery so that right ventricle can kind of recover. This of course opens the problem of sepsis and infection. So it's a very difficult problem to solve in the setting of cardiovascular surgery. Yeah.
There's another question about lung transplantation from Christian, and he is asking right ventricular function before and after lung transplantation. So what would you say? If you have a really, I think that's the question, what it's about. If you have a really, really bad right ventricle after lung transplantation, if you have, for example, a CT-APH, does it recover completely?
Good question. I would say in 95% of patients, right ventricle function recovers. It's very similar to aortic stenosis. You have an increase in afterload, in this case of the pulmonary vascular circulation. And if you release this, for example, to lung transplantation or any other surgery that relieves this pressure, what now happens is the pressure overload is gone. And therefore the right ventricle now can, of course, contract much more easily. I did, however, see patients where right ventricle function was so poor before surgery that it didn't recover, and those are a subset of patients which usually have a very poor prognosis. But I guess it's just a very, very small minority of patients where you see this. As a matter of fact, the major problem we see after lung transplantation is that the left ventricle all of a sudden starts to fail. And this again can be explained that after lung transplantation, all of a sudden we have a better cardiac output. There's more blood going through the pulmonary circulation back to the left ventricle. And therefore, all of a sudden you have a kind of a higher preload than the left ventricle was adapted to. Or maybe we were demasking left ventricular dysfunction because the patient had a low volume status at the beginning. So this is a problem we see. And then one other problem we see in such patients is that the right ventricle is actually hypercontractile after operation. And what happens is that you can have obstruction of the right ventricular outflow tract as a problem. But in general, it's very difficult for the anesthesiologists, and we in our department have a special intensive care unit that takes care of these patients, and they know the problem. You have to be very cautious in how much catecholamines you give them, how much fluids you give them, and eventually these patients usually recover, and the right ventricle in most patients is not a problem.
So there's another question from Christoph coming in. Can pulmonary hypertension cause severe tricuspid regurgitation, and any algorithm to differentiate primary TR from secondary due to pulmonary hypertension? And I want to add there a question. What do you do if a TR is missing? So you have no TR.
Okay, good question. Yes, pulmonary hypertension can cause severe tricuspid regurgitation. Why? Because, as I mentioned, in severe pulmonary hypertension, you often have a dilation of the right ventricle, and therefore you have functional TR. It's frequently the cause. However, not every patient with pulmonary hypertension has TR, and the degrees of TR, they vary greatly. Sometimes, it's very difficult to understand why one ventricle has TR and one does not. Maybe it's just a variation in the size of the annulus and maybe some anatomic features of the tricuspid valve, where some tricuspid valves are more resistant to develop tricuspid regurgitation. The important concept, however, is that as with the left heart and the mitral valve, it's not only the anodilation you have, but it's often also a form of restriction of the tricuspid leaflets. So when the right ventricle dilates, you also have some stretch on the papillary muscles of the right ventricle, which also cause some form of leaflet restriction. So it's a combination of the two. Basically what I think is important to understand is that the degree of tricuspid regurgitation does not correlate with pulmonary pressure. Now, to the second part of the question, can you differentiate between functional and structural tricuspid regurgitation? In reality, most patients have secondary or functional tricuspid regurgitation. Structural tricuspid regurgitation means you have some form of a pathology of the tricuspid valve. So what you'll be looking for is you'll be looking for a flail leaflet. You'll be looking at thickening of the valves, maybe domening indicating rheumatic heart disease, or some structural abnormality, maybe it's an Epstein. So you'd have to look for the structural abnormalities there. The big problem, however, is that sometimes it's not so clear, and that the abnormality of the tricuspid valve can be very, very subtle. And there are a number of valves which are, I would call them dysplastic. So it's not a full-blown Epstein, but it's kind of a minor variant of this or some other variant of an abnormality where it actually is a structural tricuspid regurgitation, but which you just don't appreciate. And then lastly, I think it's also important to understand when it comes to looking at the mechanism of TR, it's not only the right ventricle, it's also the right atrium. And this, I believe, is completely underappreciated in the literature and not understood. Very frequently you have dilatation of the right atrium, which also causes a stretch of the annulus, and then causes tricuspid regurgitation, which in turn causes volume overload, which causes right ventricular dilatation, which causes a larger right atrium. So it's this vicious cycle which keeps on going. And usually if you have at least moderate TR, then this progressive mechanism keeps on progressing, and then you have more and more and more and more. So I think if you have moderate TR, it's usually a point of no return, where it's very difficult to reverse it to mild or maybe even no TR. And over the years, you will probably see more and more and more of TR. Yes, so I was talking pretty much about, it's an interesting concept, and it's just, once you've understood it, and it's the same for the left and the right heart, it's easy, you will never forget, and you will interpret your echoes completely different. You had another question you wanted to know?
No, you're asking too fast, let me think. If you have no TR, what would you do? Yeah, I think that is of course, we discussed that very extensively in the right heart course and other courses. That's exactly where you need other parameters, such as, do you see low velocity across the pulmonary artery? Do you have a short pulmonary valve acceleration time? Do you have this second notch in the descending part of the pulmonary artery? If you have slanting of or D-shaped of the left ventricle, all of these are indirect signs which point to the patient having some degree of pulmonary hypertension. And this is exactly the category where your echo makes a huge difference, because you can find patients, I always say that other people do not find, which is always cool. So this is like, but it's obviously for the sake of the patient, you can find these patients early. So that's very important. I think that's very important to understand this, because very often you don't see a TR and then you think, great, no TR, I don't have pulmonary hypertension, there are no high pressures, but you have to also take a look at the findings you displayed, so to be really sure that you don't miss it. Yeah. One other thing I forgot to mention is the size of the pulmonary artery, which is also an important indicator. In most patients with pulmonary hypertension, you will have some degree of dilatation of the pulmonary artery, which is normal value of 21 to 23, somewhere in that range. So look at that as well. Good. I just want to maybe make just a short announcement, or maybe just fill you in on some of the things we've been doing in the past. And we've been very, of course, hardworking in providing new tools to learn, not only echocardiography, but also cardiology in general. And what I'd like to announce is we have an app that you can find in your App Store. You can find it on Android or in the Apple Store, which is for free, which we call the Ace of Hearts. And the general concept here is that you can test your knowledge, based on guidelines and fun questions, and see how you can actually not only test yourself, but also how you can learn. We've got thousands and thousands of questions inside, some of them with beautiful images, some with echo, some with other image modalities, some graphics and drawings. So there's a lot of information inside, and you can also play this game against someone else. Mm-hmm. So this is you can match yourself. We'll show you the trailer. Maybe we can just roll the trailer so you see what the app is all about. Yeah, it's a really fun tool, and especially the matching component, that's a lot of fun to try. There are some really hard questions, some are easy questions, but no matter if you're a beginner or advanced, you will have a lot of fun with it. So I suggest you to try it out a little bit.
Yeah, the reason we did this was because we realized that people don't have all the time in the world to learn, and it's always good to have something that you can learn in between, maybe if you're on the bus or if you're on your way to work, or maybe even while you're at work. So you have a way of learning and improving your skills, and there's kind of an algorithm built inside that kind of sees how you're doing and provides you these questions that are fit to your needs. So it's a very good training and preparation for exams. And like I said, you can always play against others. You will not find me in the app though.
So it doesn't feel like studying, but it feels like a game. So
yeah. So I've been discussing this before the webinar, and I put my name out. Yes, I'm in there, but I'm here anonymously, so you will not find me because when we started launching this in the beta phase, I got something like 800 people who wanted to play matches with me, and I was kind of afraid to lose against you out there. So that's, but in general, I think it's something you can just download and try out and send us feedback. We definitely want to know what you think about this, and we'll add more chapters, more topics, and this will be a big project.
So do we have time for another question?
Oh yeah, sure. We got
Great.
one from
Christoph, does the shape of the TR curve in Doppler give information if TR or elevated pulmonary pressure is responsible for right heart dilatation? Amazing question. I would also ask this. What's your take on this?
Does the shape of the TR curve in Doppler, let me see the question once more, give you information if TR or elevated pulmonary pressure is responsible? Indirectly, yes. Why? Because if you have a triangular shape of the signal, in other words, a very early peak, usually not a high velocity, that means you have pressure equilibration between the right ventricle and the right atrium, which means that TR is severe. The only problem is that you cannot be sure that this patient doesn't also have high pulmonary pressures, because in this situation, you cannot assess pulmonary pressures. And I've seen patients who had very low velocities because there is no gradient, but still had very, very high pulmonary pressures. So in this situation, the pressure in the right atrium is extremely high. In our report, we have this phrase, and it goes, severe pulmonary right pressure, tricuspid regurgitation with equilibration of pressure between the right atrium and the right ventricle. We cannot determine pulmonary pressure because we cannot estimate right atrial pressures anymore. So this is the phrase we use in our report, and this again is one of the reasons you need right heart cath.
Yeah.
So that's this here. Maybe we have just 5 more minutes. I'll just show you maybe another case of a patient with a right heart problem. This is a patient who was transplanted. What you see here is a patient who had heart transplantation 3 years ago. And usually these patients have a very good prognosis. We know that the survival rate is quite high. I don't know the figures at this point, but you see patients that live 15, 20 years even after transplantation, even more. And this patient had a problem 3 years after, and this here is now his echo. I guess you will appreciate that we have poor left ventricular function. Maybe you can just...
Yeah, sure. The left ventricular function is poor, and there's also something here in the apex. Nice to see a thrombus here.
Yeah, so this is clearly not a normal left ventricle.
As well as the right ventricle, also functionally right ventricle is deteriorated here.
Right, and when you look at this focused view, I guess here you would not even need strain. I think the visual assessment alone is enough to tell you this is very, very poor right ventricle function. And if you have a situation of a patient after transplantation who has a very, very poor left and right ventricle function, this could be many things. And one of the most common things that you have to think about is that the patient has some form of transplant rejections. So in this case, that would be my probably most likely guess. Obviously, the thrombus in there is also related to the poor left ventricular function, but not always. I'll come to the conclusion of this case later, but let's take a look at the strain. Martin, maybe you can comment on the right ventricular strain.
Again, you see right ventricular strain, and as you mentioned, Tommy, basically we wouldn't have needed it, but you see really low values, -4, -7, -9, really, really poor right ventricular function.
Yeah, so very poor right ventricular function. It's nicely also displayed with this here. Now, the reason this patient actually had this poor right ventricular function was something we already saw in a previous case. He had a right heart infarct. This is a coronary angiogram. You see that the right coronary artery is completely occluded. Not showing you the left, but he also had significant stenosis there. So patients with transplantation, they can have both microvascular problems, and they can also have macroscopic, or let's put stenosis of the large coronary artery. So this is a patient who actually had coronary artery disease. That's why he has poor left ventricular function and why he also has poor right ventricular function. Okay, so I see that we have a significant number of people in this webinar. I see the statistics here where over 75 people, of this exclusive club of people we invited to take part of this webinar. Maybe just a few final statements on this. This is something, as I mentioned at the beginning, we want to do more and more frequently, because we don't only want to push content to you, but we also want to be a little bit, we might call it your mentors, and give you the chance to ask questions, and this is exactly why we're doing this. So we are not going to stop here. If you have any further questions, please, you can put them online and send us them in the chat box, in the function you have, and please don't forget to also include your email in the comment field below, because obviously we need to know where you're from, and so that we can give you a response to this. And as a final statement, I definitely want to thank all of you out there, this community that we've built. It's a growing community. We have so many different things which are going on. Visit us, subscribe to our newsletter so that you find out what the newest things are that we're producing, and newest things that might be of help to you. And in conclusion, I can only thank you, and particularly Martin, for being with me here in this webinar, and hope to see you in some of our future courses.
Thank you very much.
Thank you.